Welcome to this video entitled Acute Kidney Injury, abbreviated as AKI, and Chronic Kidney Disease, abbreviated as CKD, a clinical pharmacology tutorial. Welcome to this session on renal physiology, acute kidney injury, and chronic kidney disease. Before we discuss kidney diseases, we must understand normal kidney function. The kidneys are powerful organs that maintain internal balance. They filter blood through the glomeruli. This process removes waste products and excess substances from the body. Every day, the kidneys carefully control fluid balance, electrolytes, and acid-base status. After filtration, the kidney tubules reabsorb important substances. These include water, glucose, sodium, and other essential molecules. The kidneys also secrete certain substances into the urine. This helps eliminate toxins, medications, and metabolic waste. The kidneys continuously adjust their function through autoregulation. This allows stable filtration despite changes in blood pressure. Now let us explore acute kidney injury, also known as AKI. Acute kidney injury is a sudden decline in kidney function. It causes reduced ability to remove waste and maintain homeostasis. Understanding acute kidney injury requires knowledge of its pathophysiology. Kidney injury can develop from reduced blood supply. This is called prerenal kidney injury. Examples include dehydration, shock, and severe blood loss. The kidney itself can also be directly damaged. This is called intrinsic kidney injury. It may result from toxins, inflammation, infections, or ischemia. A blockage preventing urine flow causes postrenal kidney injury. This may occur due to stones, tumors, or urinary obstruction. The severity of acute kidney injury is classified using KDIGO staging. KDIGO staging helps clinicians identify the degree of kidney damage. It uses changes in serum creatinine and urine output. Accurate staging guides treatment decisions and predicts outcomes. Kidney injury also changes how drugs behave in the body. This involves pharmacokinetic changes. Drug elimination may decrease because the kidneys cannot clear medications effectively. As a result, drug levels may rise and cause toxicity. Pharmacodynamic changes also occur. Patients may respond differently to medications during kidney injury. Therefore, careful dose adjustments and monitoring are essential. We will also examine chronic kidney disease, or CKD. Chronic kidney disease is a long-term decline in kidney structure and function. It develops gradually and may progress over years. Common causes include diabetes, hypertension, and chronic inflammation. Chronic kidney disease progression involves ongoing kidney damage and loss of functioning nephrons. The remaining nephrons work harder to compensate. Over time, this increases stress and accelerates kidney decline. Chronic kidney disease is classified using staging criteria. These stages are based mainly on kidney filtration capacity. Understanding chronic kidney disease stages helps predict complications and guide management. Finally, we will apply pharmacological principles in chronic kidney disease care. Treatment focuses on slowing disease progression. It also manages complications such as anemia, electrolyte imbalance, and cardiovascular risk. Effective therapy requires understanding kidney function, drug behavior, and patient-specific factors. The goal is to protect remaining kidney function and improve patient outcomes. Let us begin by understanding the basic anatomy of the kidney. The kidneys are highly specialized organs designed to maintain balance in the body. They remove waste products from the blood. They regulate water, electrolytes, and blood pressure. They also help control important hormones and metabolic functions. Each kidney contains about 1 million functional units called nephrons. The nephron is the main structure responsible for urine formation. It performs filtration, reabsorption, and secretion. Think of the nephron as a microscopic processing system. It carefully decides what stays in the body and what is removed. Now, let us look at the overall kidney structure. The kidney has two major regions. The outer region is called the cortex. The inner region is called the medulla. The cortex contains many important filtering structures. The medulla contains specialized tubules that help concentrate urine. Together, these regions allow the kidney to perform its complex functions. Each nephron has two major sections. The first section is the renal corpuscle. The renal corpuscle is the starting point of filtration. It contains two important structures. The first is the glomerulus. The glomerulus is a network of tiny blood vessels. Here, blood is filtered under pressure. Small molecules pass through. These include water, electrolytes, and waste products. Large proteins and blood cells normally remain in the bloodstream. The second part of the renal corpuscle is Bowman's capsule. Bowman's capsule surrounds the glomerulus. It collects the filtered fluid. This fluid then moves into the renal tubule. The renal tubule is responsible for modifying the filtrate. The first part is the proximal convoluted tubule, also called the PCT. The proximal convoluted tubule performs major reabsorption. It returns valuable substances back into the blood. These include glucose, amino acids, sodium, and water. Next is the loop of Henle. This structure plays a key role in concentrating urine. It creates the concentration gradient needed to conserve water. The descending and ascending limbs have different functions. Together, they help maintain fluid balance. After the loop of Henle comes the distal convoluted tubule. The distal convoluted tubule fine-tunes electrolyte levels. It adjusts sodium, potassium, and acid-base balance. Finally, the filtrate reaches the collecting duct. The collecting duct determines the final concentration of urine. It responds to hormones that control water retention. Through these coordinated steps, the nephron maintains internal balance. Understanding nephron anatomy is essential. It helps us understand kidney diseases. It also explains how medications affect kidney function. The nephron is the foundation of renal physiology. Now let us explore one of the most important kidney functions. This is called glomerular filtration. Glomerular filtration is the first step in urine formation. It happens inside the renal corpuscle of the nephron. The glomerulus acts like a highly specialized filtering system. It allows certain substances to move from blood into the nephron. However, this filtration process is selective. The kidney does not simply allow everything to pass through. It carefully controls what enters the filtrate. This protects important substances that the body needs. The filtration barrier has three main components. The first component is the fenestrated endothelium. This is the inner lining of the glomerular blood vessels. It contains tiny openings called fenestrations. These openings allow water and small molecules to pass through. However, they prevent blood cells from leaving the circulation. The second component is the basement membrane. This is a supportive layer between the endothelium and podocytes. The basement membrane has a negative electrical charge. This negative charge helps repel negatively charged proteins. A major example is albumin. Normally, albumin remains in the bloodstream. Loss of albumin into urine suggests damage to the filtration barrier. The third component is the podocytes. Podocytes are specialized cells surrounding the glomerular capillaries. They contain small extensions called foot processes. Between these processes are filtration spaces called slit diaphragms. These structures provide the final level of filtration control. Together, These three layers create a highly selective barrier. The goal is simple: allow useful small molecules to pass. Keep large and important molecules inside the blood. The normal filtrate contains water and small dissolved substances. It includes electrolytes such as sodium and potassium. It also contains glucose and amino acids. Waste products such as urea and creatinine are filtered. These substances eventually contribute to urine formation. Normally, glucose is filtered but later reabsorbed by the tubules. This prevents loss of valuable energy sources. Creatinine and urea are different. They are waste products that the body needs to eliminate. The glomerulus therefore acts as the kidney's first quality control checkpoint. When this barrier is damaged, kidney disease can develop. Protein leakage, reduced filtration, and abnormal urine findings may appear. Understanding glomerular filtration helps us understand acute kidney injury and chronic kidney disease. It also explains how changes in kidney function affect medication handling. The glomerulus is the gateway where blood becomes the starting point of urine formation. After filtration, the next major step in urine formation is tubular reabsorption. This process happens mainly in the proximal convoluted tubule, also called the PCT. The proximal convoluted tubule is the kidney's main recovery system. Its job is to return valuable substances back into the bloodstream. The body does not want to lose essential nutrients. So, the kidney carefully reclaims them. The proximal convoluted tubule performs what we call bulk reabsorption. It reabsorbs about 60 to 70% of filtered water. It also recovers large amounts of sodium, chloride, potassium, and bicarbonate. These substances are essential for maintaining fluid balance and normal body function. The proximal convoluted tubule also has an important role in nutrient conservation. Under normal conditions, it reabsorbs almost 100% of filtered glucose. It also completely reabsorbs amino acids. This prevents the loss of valuable energy sources and building blocks. A key driver of this entire process is the sodium-potassium ATPase pump. This pump is located on the basolateral membrane of tubular cells. It actively moves sodium out of the cell. At the same time, it brings potassium into the cell. This creates a sodium gradient. That gradient provides the energy needed for many transport processes. In simple terms, the sodium-potassium ATPase pump powers kidney reabsorption. One important transporter in the proximal convoluted tubule is SGLT2. This stands for sodium glucose link transporter 2. Sodium glucose link transporter 2 helps move glucose from the tubular fluid back into the blood. It transports glucose together with sodium. This mechanism is extremely important in maintaining normal blood glucose levels. Sodium glucose link transporter 2 has also become an important target for modern medications. Another important transporter is the sodium hydrogen exchanger. This is called NHE3. Sodium hydrogen exchanger 3 plays a major role in bicarbonate recovery. Bicarbonate is essential for maintaining normal acid-base balance. The kidney uses sodium hydrogen exchanger 3 to exchange sodium movement with hydrogen secretion. This allows the body to conserve bicarbonate. It also helps regulate blood pH. The proximal convoluted tubule therefore performs multiple tasks at the same time. It recovers essential substances. It controls fluid balance. It supports electrolyte stability. It maintains acid-base regulation. Understanding proximal convoluted tubule function is critical. Many kidney diseases and medications affect these transport systems. Damage to the proximal convoluted tubule can disrupt normal body balance. The proximal convoluted tubule is truly the kidney's main recycling center. Now let us continue our journey through the nephron. After the proximal convoluted tubule, the filtrate enters the loop of Henle. The loop of Henle has a very important role in urine concentration. It helps the kidney decide how much water should be conserved. The loop has two main parts: the descending limb and the ascending limb. Each part has a different function. The descending limb is highly permeable to water. This means water can easily move out of the tubular fluid. As the filtrate moves deeper into the kidney medulla, the surrounding environment becomes more concentrated. Water leaves the tubule through osmosis. This causes the filtrate to become more concentrated. The descending limb mainly controls water movement. It does not actively remove large amounts of solutes. Next, the filtrate reaches the thick ascending limb. This section behaves very differently. The thick ascending limb is impermeable to water. Water cannot leave this part of the nephron. Instead, it actively removes electrolytes from the filtrate. Sodium, potassium, and chloride are transported out of the tubule. The key transporter responsible is the sodium-potassium 2-chloride co-transporter. This transporter is known as NKCC2. Sodium-potassium 2-chloride co-transporter moves sodium, potassium, and chloride together across the tubular membrane. This process requires energy and active transport. By removing these solutes, the ascending limb changes the concentration of the kidney medulla. This creates what is called the medullary osmotic gradient. The medullary osmotic gradient is essential for water conservation. It allows the kidney to produce concentrated urine when needed. Think of the loop of Henle as a concentration system. The descending limb allows water to leave. The ascending limb removes salts but keeps water inside. Together, these two actions create a powerful mechanism. This mechanism is called the countercurrent multiplication system. It allows the kidney to adapt to different hydration states. During dehydration, the kidney can conserve water. During excess fluid intake, it can remove more water. The loop of Henle is therefore central to maintaining body fluid balance. Its function depends on precise movement of water and electrolytes. Disruption of these processes can affect urine concentration. It can also influence electrolyte levels in the body. Understanding the loop of Henle helps explain many kidney disorders. It also explains how certain diuretic medications work. The loop of Henle is a remarkable example of kidney engineering. It transforms filtered fluid into urine that matches the body's needs. As the filtrate continues through the nephron, it reaches the final adjustment areas. These areas are the distal convoluted tubule and the collecting duct. Here, the kidney performs fine control. The goal is to carefully adjust electrolytes, water, and acid-base balance. The distal convoluted tubule, also called the DCT, comes after the loop of Henle. The distal convoluted tubule is responsible for selective electrolyte regulation. One important transporter in this region is the sodium chloride co-transporter. This transporter is called NCC. Sodium chloride co-transporter moves sodium and chloride from the tubular fluid back into the bloodstream. This process helps regulate blood pressure and electrolyte balance. The sodium chloride co-transporter is clinically important. It is the target of thiazide diuretics. When thiazides block sodium chloride co-transporter, sodium and chloride reabsorption decreases. This promotes increased sodium and water loss in urine. Now let us move to the collecting duct. The collecting duct is the final decision point for urine composition. It determines how concentrated or diluted the urine becomes. The collecting duct contains specialized cells. These include principal cells and intercalated cells. Principal cells are mainly involved in sodium and potassium regulation. They contain a channel called ENAC. ENAC allows sodium to move from the urine back into the blood. This helps maintain blood volume and electrolyte balance. ENAC activity is influenced by hormones such as aldosterone. The medication amiloride works by blocking ENAC. This reduces sodium reabsorption. It also helps prevent excessive potassium loss. Principal cells also contain ROMK channels. ROMK allows potassium secretion into the urine. This mechanism helps maintain normal potassium levels in the body. However, excessive potassium loss can lead to low potassium levels. Now let us discuss intercalated cells. These cells are essential for acid-base regulation. They help maintain the body's normal pH. The kidneys regulate acidity by controlling hydrogen ions and bicarbonate. Some intercalated cells secrete hydrogen ions into the urine. Others help conserve or generate bicarbonate. Bicarbonate acts as an important buffer in the blood. Together, these processes maintain acid-base balance. The distal tubule and collecting duct therefore provide precise control. They fine-tune the final composition of urine. They regulate sodium, potassium, water, and pH. This final adjustment is essential for survival. Understanding these segments helps explain kidney diseases. It also explains how many diuretic medications work. The distal nephron is the kidney's final control center before urine leaves the body. Now let us explore another important kidney process called tubular secretion. Tubular secretion is the movement of substances from the blood into the tubular fluid. It is the opposite direction of reabsorption. Instead of returning substances to the bloodstream, the kidney actively removes them. This process helps the body eliminate unwanted compounds. These include toxins, metabolic waste, and certain medications. Tubular secretion mainly occurs in the proximal convoluted tubule. The proximal convoluted tubule contains specialized transport systems. These transport systems move substances from the peritubular capillaries into the tubular lumen. The peritubular capillaries surround the nephron after filtration. Substances leave the blood and enter the urine pathway. This allows the kidney to increase removal of specific compounds. Tubular secretion is an active process. It requires energy and specific membrane transport proteins. Two major transporter groups are involved. The first group is the organic anion transporters. These are called OATs. Organic anion transporters transport negatively charged molecules. They help remove many drugs and metabolic substances from the body. The second group is the organic cation transporters. These are called OCTs. Organic cation transporters transport positively charged molecules. Together, organic anion transporters and organic cation transporters play a major role in drug elimination. Many medications depend on these transport systems. For example, penicillins are actively secreted by the kidney. This helps remove the drug after it performs its therapeutic action. Some non-steroidal anti-inflammatory drugs, also called NSAIDs, can interact with renal transport processes. This may affect kidney function, especially in vulnerable patients. Tubular secretion is also important for removing uric acid. Uric acid is a waste product formed during purine metabolism. The kidney regulates its levels through filtration and secretion. Changes in these processes can contribute to conditions such as hyperuricemia. Understanding tubular secretion is extremely important in clinical pharmacology. Drug levels can change when kidney function is impaired. Reduced secretion may cause medications to accumulate. This increases the risk of toxicity. Therefore, kidney function must be considered when prescribing and dosing medications. Tubular secretion is the kidney's active clearance system. It works together with filtration and reabsorption. Together, these processes determine the final composition of urine. The kidney is not just a filter. It is an intelligent organ that selectively removes substances and maintains internal balance. Now let us discuss how the kidney controls its own blood supply. Renal blood flow, or RBF, is essential for kidney function. The kidneys receive a large amount of blood every minute. This allows continuous filtration and waste removal. A key measurement of kidney function is the glomerular filtration rate, or GFR. Glomerular filtration rate depends on maintaining stable blood flow through the glomerulus. The kidney has special mechanisms to protect this process. These mechanisms are called autoregulation. Autoregulation keeps renal blood flow and glomerular filtration rate relatively constant. This happens even when blood pressure changes. The first autoregulatory mechanism is the myogenic mechanism. This involves the smooth muscle of the afferent arteriole. When blood pressure rises, the vessel wall stretches. The smooth muscle responds by contracting. This reduces excessive blood flow into the glomerulus. It protects the delicate filtration system. When blood pressure falls, the vessel relaxes. This allows more blood to enter the kidney. The second mechanism is tubuloglomerular feedback. This system connects the nephron with the glomerulus. It depends on a specialized structure called the macula densa. The macula densa senses sodium and chloride levels in the tubular fluid. If too much sodium chloride reaches the macula densa, it signals reduced filtration. The afferent arteriole constricts. This decreases pressure inside the glomerulus. It helps prevent excessive filtration. Now let us look at hormonal regulation. Several hormones influence renal blood flow and filtration. One major system is the renin-angiotensin-aldosterone system. This is commonly called RAAS. When kidney perfusion decreases, renin release increases. Renin activates the production of angiotensin II. Angiotensin II causes vasoconstriction. It helps maintain blood pressure and kidney perfusion. It also stimulates aldosterone release. Aldosterone increases sodium reabsorption. This promotes water retention and supports blood volume. Prostaglandins also affect kidney circulation. Important examples include PGE2 and PGI2. These substances dilate the afferent arteriole. This helps maintain blood flow into the glomerulus. They provide protection during reduced kidney perfusion. Medications that block prostaglandin production, such as non-steroidal anti-inflammatory drugs, can interfere with this process. Another important hormone is antidiuretic hormone, or ADH. Antidiuretic hormone controls water retention. It increases water reabsorption in the collecting duct. Atrial natriuretic peptide, or ANP, works differently. It promotes sodium and water loss. This helps reduce excess fluid volume. Together, these mechanisms maintain kidney stability. They balance blood flow, filtration, and fluid control. Understanding renal regulation is essential. It explains how kidneys respond to stress. It also helps explain how medications can affect kidney function. Now let us introduce one of the most important clinical kidney emergencies. This condition is called acute kidney injury, or AKI. Acute kidney injury is a sudden decline in kidney function. It develops over a short period of time. Usually, this occurs within hours to days. The key feature is an abrupt reduction in glomerular filtration rate. The glomerular filtration rate, or GFR, reflects how well the kidneys filter blood. When glomerular filtration rate falls, the kidneys cannot remove waste effectively. As a result, harmful substances begin to accumulate. One major consequence is the buildup of nitrogenous waste products. These include urea and creatinine. Normally, the kidneys remove these substances through urine. During acute kidney injury, their levels increase in the blood. This condition is called azotemia. Acute kidney injury also affects the body's fluid and electrolyte balance. The kidneys regulate water, sodium, potassium, and acid-base balance. When kidney function suddenly declines, these systems become disrupted. Patients may retain excess fluid. This can lead to swelling, high blood pressure, or breathing difficulties. Electrolyte abnormalities may also occur. A major concern is increased potassium levels. Hyperkalemia can affect heart rhythm. Acid-base disturbances can also develop. The body may become unable to remove excess acids. Clinically, acute kidney injury often presents with reduced urine production. This is called oliguria. Oliguria means a lower than normal urine output. However, some patients may still produce urine despite kidney injury. Therefore, urine output alone does not always detect acute kidney injury. Another important clinical marker is serum creatinine. Serum creatinine, abbreviated as SCR, rises when kidney filtration decreases. Creatinine is produced by normal muscle metabolism. Healthy kidneys remove it from the blood. When filtration slows, creatinine accumulates. A rising serum creatinine level suggests worsening kidney function. Doctors monitor creatinine changes to diagnose and assess acute kidney injury severity. AKI can occur for many different reasons. These include reduced blood flow to the kidney. They also include direct kidney damage or urinary obstruction. Understanding acute kidney injury requires recognizing the balance between kidney structure and function. Early detection is important. Prompt management can prevent further injury. Acute kidney injury is not just a laboratory abnormality. It represents a major disturbance in the body's ability to maintain balance. The kidneys are essential regulators of life. When they suddenly fail, the effects can be widespread. Now let us understand how acute kidney injury is classified. The most widely used system is the KDIGO classification. KDIGO stands for Kidney Disease Improving Global Outcomes. This system helps clinicians assess the severity of acute kidney injury. It uses two main measurements. The first is serum creatinine, or SCR. The second is urine output. Together, these measurements show how much kidney function has changed. Acute kidney injury is divided into 3 stages. Stage 1 represents the mildest form of injury. In Stage 1, serum creatinine rises to 1.5 to 1.9 times the patient's baseline level. It can also be diagnosed when creatinine increases by at least 0.3 milligrams per deciliter. Another sign is reduced urine production. Urine output may fall below 0.5 milliliters per kilogram per hour. This reduction must continue for 6 to 12 hours. At this stage, early recognition is important. Treatment may prevent progression to more severe injury. Stage 2 represents a moderate level of kidney injury. Serum creatinine rises to 2 to 2.9 times the baseline value. Urine output also becomes significantly reduced. It may remain below 0.5 milliliters per kilogram per hour. This continues for at least 12 hours. Stage 2 suggests a greater loss of filtration ability. Closer monitoring and intervention are usually required. Stage 3 is the most severe category. This represents major kidney dysfunction. Serum creatinine may increase to 3 times the baseline value. Alternatively, The creatinine level may reach 4 mg per deciliter or higher. Stage 3 also includes patients who require renal replacement therapy. This includes treatments such as dialysis. Another severe feature is anuria. Anuria means almost complete absence of urine production. It is defined as no urine output for at least 12 hours. KDIGO staging is important because acute kidney injury severity affects outcomes. Higher stages are associated with greater risk of complications. These include fluid overload, electrolyte disturbances, and longer hospital stays. The classification also guides treatment decisions. It helps clinicians identify patients who need urgent management. Understanding KDIGO staging allows healthcare professionals to communicate kidney injury clearly. It transforms changes in creatinine and urine output into meaningful clinical information. Early identification of acute kidney injury can make a major difference in patient care. Now let us explore one of the most common causes of acute kidney injury. This is called prerenal acute kidney injury. Prerenal acute kidney injury accounts for about 60 to 70% of acute kidney injury cases. The word prerenal means the problem occurs before the kidney itself. The main issue is reduced blood supply to the kidneys. The kidney structure is initially normal. There is no major direct damage to the kidney tissue at the beginning. The problem is reduced kidney perfusion. The kidneys need continuous blood flow to maintain filtration. When blood flow decreases, kidney function quickly declines. One major cause is true hypovolemia. This means the body has lost actual fluid volume. Examples include severe dehydration. It can occur from vomiting, diarrhea, or inadequate fluid intake. Another example is hemorrhage. Major blood loss reduces circulating volume. Severe burns can also cause fluid loss. These conditions reduce the amount of blood reaching the kidneys. Another cause is decreased effective circulating volume. In this situation, total body fluid may not be low. However, the kidney senses reduced effective blood flow. Heart failure is a common example. The heart cannot pump enough blood forward. As a result, kidney perfusion decreases. Sepsis is another important cause. Widespread infection causes major changes in circulation. Blood vessels may dilate. Blood pressure can fall. The kidneys receive less effective blood flow. Liver cirrhosis can also contribute. Fluid may accumulate in the body. However, the kidneys may still perceive low circulating volume. The pathophysiology follows a simple sequence. First, renal blood flow decreases. Less blood reaches the glomerulus. The pressure inside the glomerular capillaries falls. This reduces the force driving filtration. As a result, the glomerular filtration rate decreases. A lower glomerular filtration rate means less waste removal. Creatinine and urea begin to accumulate. Urine production may also decrease. The kidney attempts to compensate. It activates systems such as renin-angiotensin-aldosterone system. This promotes sodium and water retention. Initially, prerenal acute kidney injury can be reversible. Restoring blood flow may restore kidney function. However, prolonged reduced perfusion can become dangerous. Persistent ischemia can damage kidney cells. This may progress to intrinsic kidney injury. Understanding prerenal acute kidney injury is essential. It reminds us that the kidney depends on adequate circulation. Protecting kidney blood flow is a major step in preventing acute kidney injury. Now let us look at how medications can trigger prerenal acute kidney injury. A classic example is the use of non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs are non-steroidal anti-inflammatory drugs. They are commonly used for pain and inflammation. Examples include drugs such as ibuprofen and similar agents. To understand their kidney effects, we first need normal physiology. The kidney carefully regulates blood flow into the glomerulus. A key structure involved is the afferent arteriole. This vessel controls blood entry into the filtering unit. During stress, the kidney produces protective substances. These substances are called prostaglandins. Important examples are PGE2 and PGI2. Prostaglandins help dilate the afferent arteriole. This widening allows more blood to enter the glomerulus. It helps maintain filtration when kidney perfusion is reduced. This protective mechanism is especially important during dehydration or low blood volume. Now let us see what non-steroidal anti-inflammatory drugs do. Non-steroidal anti-inflammatory drugs block enzymes called cyclooxygenases. These enzymes are known as COX enzymes. COX enzymes are needed for prostaglandin production. When non-steroidal anti-inflammatory drugs inhibit COX enzymes, prostaglandin synthesis decreases. The kidney loses an important protective signal. The afferent arteriole can no longer maintain its normal dilation. Instead, vasoconstriction becomes dominant. The afferent arteriole narrows. Less blood enters the glomerulus. Glomerular pressure falls. As a result, the glomerular filtration rate decreases. This can cause a sudden decline in kidney function. The patient may develop prerenal acute kidney injury. The risk is higher in certain situations. These include dehydration. They also include heart failure, older age, and existing kidney impairment. The combination of non-steroidal anti-inflammatory drugs with other medications can increase risk. For example, drugs affecting the renin-angiotensin-aldosterone system may further reduce kidney filtration. This is sometimes called the triple whammy effect. It highlights the importance of medication review in vulnerable patients. Non-steroidal anti-inflammatory drugs do not usually damage the kidney directly at first. Their main problem is changing the kidney's blood flow regulation. They remove the prostaglandin protection that maintains filtration. Understanding this mechanism helps clinicians use non-steroidal anti-inflammatory drugs safely. It also explains why monitoring kidney function is important. The kidney depends on a delicate balance between blood flow and filtration. Non-steroidal anti-inflammatory drugs can disrupt this balance and trigger acute kidney injury. Now let us explore another important medication-related cause of prerenal acute kidney injury. This involves angiotensin-converting enzyme inhibitors and angiotensin receptor blockers. These medications are commonly used in hypertension, heart failure, and kidney protection. Examples include angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. To understand their kidney effects, we first need to understand normal physiology. The glomerulus requires a specific pressure to filter blood. This filtration pressure depends on the balance between two arterioles. The afferent arteriole brings blood into the glomerulus. The efferent arteriole carries blood away. A key hormone involved is angiotensin II. Angiotensin II normally constricts the efferent arteriole. This narrowing increases pressure inside the glomerulus. The increased pressure helps maintain filtration. This becomes especially important when blood flow to the kidney is reduced. Angiotensin II acts as a support system for glomerular filtration rate. Now let us see what angiotensin-converting enzyme inhibitors do. Angiotensin-converting enzyme inhibitors block the angiotensin-converting enzyme. This reduces the formation of angiotensin II. Angiotensin II receptor blockers work differently. They block the angiotensin II type 1 receptor. The result is similar. The effects of angiotensin II are reduced. The efferent arteriole loses its normal constriction. It begins to dilate. When the efferent arteriole widens, blood leaves the glomerulus more easily. The pressure inside the glomerulus decreases. This reduces the driving force for filtration. As a result, the glomerular filtration rate can fall. In some patients, this can trigger prerenal acute kidney injury. The risk is higher when kidney perfusion is already reduced. Examples include dehydration. It also occurs in severe heart failure or low blood pressure states. This does not mean angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers are harmful drugs. They are valuable medications. They can slow kidney disease progression in many patients. They reduce blood pressure and protect certain organs. The key is understanding when the kidney depends heavily on angiotensin II. In situations of reduced kidney blood flow, this hormone may be maintaining filtration. Blocking its action can reveal reduced renal reserve. That is why kidney function and potassium levels are monitored after starting these medications. Understanding this mechanism helps explain a delicate balance. Angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers can protect kidneys in the right setting. But in vulnerable situations, they can reduce filtration. The kidney's ability to adapt depends on precise control of blood flow and pressure. Now let us discuss intrinsic acute kidney injury. This type of acute kidney injury occurs when the kidney tissue itself is damaged. A major example is acute tubular necrosis, also called AKIN. Acute tubular necrosis is one of the most common forms of intrinsic renal injury. It mainly affects the tubular epithelial cells. These cells are responsible for important kidney functions. Acute tubular necrosis can develop through two major mechanisms. The first is ischemic acute tubular necrosis. Ischemic acute tubular necrosis occurs after prolonged reduction in kidney blood flow. It often begins as prerenal acute kidney injury. If reduced perfusion is not corrected, the injury progresses. The kidney cells receive inadequate oxygen. Without enough oxygen, cellular energy production decreases. ATP levels fall. ATP is essential for normal cell function. When ATP is depleted, tubular cells become injured. Severe injury leads to cell death. The second type is nephrotoxic acute tubular necrosis. This occurs when substances directly damage tubular cells. Many toxins and medications can cause this injury. Examples include certain antibiotics, contrast agents, and other nephrotoxic substances. The kidney is vulnerable because it receives high blood flow. It also concentrates many substances inside the tubules. This increases exposure to harmful compounds. The pathology of acute tubular necrosis explains the clinical features. Damaged tubular cells begin to detach. These cells fall into the tubular lumen. This process is called cell sloughing. The detached cells combine with proteins. They form obstructive material inside the tubules. This causes blockage of tubular flow. The pressure inside the tubule increases. Filtrate may leak back into the bloodstream. This is called back leak of filtrate. The result is reduced effective filtration. Glomerular filtration rate decreases. Waste products begin to accumulate. Patients may develop rising serum creatinine. Urine findings can provide important clues. A classic finding is the presence of dirty brown, granular casts. These casts represent damaged tubular cells and proteins. They appear in urine microscopy. Another useful clinical marker is the fractional excretion of sodium. This is called FENa. In acute tubular necrosis, fractional excretion of sodium is often greater than 2%. This reflects impaired tubular sodium reabsorption. The injured tubules cannot effectively conserve sodium. Understanding acute tubular necrosis is important. It shows how kidney injury can progress from a blood flow problem to structural damage. Early recognition of prerenal acute kidney injury can prevent progression. Once tubular cells are injured, recovery may take longer. The kidney has remarkable ability to repair itself. However, severe tubular injury requires careful management and monitoring. Now let us look deeper into nephrotoxic acute tubular necrosis. Nephrotoxic acute tubular necrosis occurs when medications or toxins directly injure kidney tubular cells. The proximal convoluted tubule is especially vulnerable. This is because it actively transports and concentrates many substances. One important example is aminoglycoside toxicity. Aminoglycosides include drugs such as gentamicin. These antibiotics are effective against many serious infections. However, they can damage the kidneys. Aminoglycosides accumulate inside proximal tubular cells. They collect within cellular structures called lysosomes and mitochondria. Inside these structures, they disrupt normal cell function. They increase oxidative stress. Oxidative stress damages proteins, membranes, and cellular DNA. Mitochondrial injury reduces energy production. As ATP levels fall, tubular cells lose their ability to function. Severe injury leads to cell death. This results in acute tubular necrosis. The risk of aminoglycoside kidney injury increases with higher doses. It also increases with prolonged treatment and existing kidney impairment. Another important cause is radiocontrast media. Contrast agents are used in many imaging procedures. In some patients, they can trigger kidney injury. Contrast-associated kidney injury involves multiple mechanisms. One mechanism is intrarenal vasoconstriction. Blood vessels inside the kidney become narrower. This reduces blood flow to the renal medulla. The medulla already operates in a low oxygen environment. Reduced blood supply can worsen oxygen deficiency. This creates medullary hypoxia. Contrast media can also increase free radical production. Free radicals cause oxidative damage. They injure tubular cells and impair kidney function. Other medications can also cause nephrotoxic acute tubular necrosis. Vancomycin is an important example. It is widely used for serious bacterial infections. In some patients, it can cause tubular injury. The risk increases with high drug levels and prolonged exposure. Amphotericin B is another nephrotoxic medication. It is used to treat serious fungal infections. It can cause kidney injury by affecting tubular cell membranes. It may also cause electrolyte disturbances. Cisplatin is a chemotherapy medication. It can accumulate in kidney tubular cells. This causes direct cellular toxicity. It can lead to tubular injury and reduced kidney function. Understanding drug-induced acute tubular necrosis is essential in clinical practice. Many nephrotoxic medications are life-saving. The goal is not always to avoid them. The goal is to use them carefully. This includes dose adjustment, monitoring kidney function, and recognizing risk factors. Protecting the kidneys requires understanding how drugs interact with renal physiology. The kidney is a major organ for drug handling. When injured, its ability to tolerate toxic exposures decreases. Now let us explore other important causes of intrinsic and postrenal acute kidney injury. Intrinsic acute kidney injury occurs when there is direct damage to kidney structures. Two important examples are acute interstitial nephritis and glomerulonephritis. First, let us discuss acute interstitial nephritis. This condition is called AKIN. Acute interstitial nephritis involves inflammation of the kidney interstitium. The interstitium is the tissue surrounding the kidney tubules. The inflammation affects normal tubular function. Acute interstitial nephritis is often caused by an immune or allergic response. Medications are common triggers. Examples include penicillins and proton pump inhibitors. The immune system reacts against the kidney tissue. This causes swelling and inflammatory cell infiltration. As the inflammation increases, kidney function declines. Patients may develop rising serum creatinine. Urine findings can provide important clues. One marker associated with acute interstitial nephritis is urinary eosinophils. Eosinophils are immune cells often involved in allergic reactions. Their presence can suggest an inflammatory drug reaction. Another important intrinsic cause is acute glomerulonephritis. This condition affects the glomerulus. The glomerulus is the kidney's filtration structure. Inflammation damages the filtration barrier. This can allow abnormal substances to leak into urine. Patients may develop blood or protein in the urine. One example is lupus nephritis. This occurs when autoimmune inflammation affects the kidney. The immune system attacks normal kidney structures. This reduces filtration ability. Now let us move to postrenal acute kidney injury. Postrenal acute kidney injury occurs when urine flow is blocked. The kidney may produce urine normally. However, the urine cannot leave the urinary system. This causes pressure to build up. The increased pressure reduces filtration. Postrenal acute kidney injury accounts for about 5 to 10% of acute kidney injury cases. Common causes include urinary obstruction. One cause is benign prostatic hyperplasia, or BPH. An enlarged prostate can block urine flow. Kidney stones can also obstruct the urinary tract. Tumors may compress or block urinary passages. Certain medications can also contribute. Anticholinergic drugs are an example. These medications can reduce bladder contraction. This may cause urinary retention. When urine remains trapped, kidney pressure increases. Prolonged obstruction can damage kidney tissue. Early recognition is important. Relieving the obstruction can restore kidney function. Understanding these different acute kidney injury patterns helps clinicians identify the cause. Prerenal injury affects blood flow. Intrinsic injury damages kidney tissue. Postrenal injury blocks urine flow. Each mechanism requires a different approach to treatment. Let us apply our understanding of acute kidney injury to a clinical case. This case involves prerenal acute kidney injury caused by sepsis. Our patient is Mr. John. He is a 65-year-old man admitted with septic shock. Septic shock is a severe infection causing dangerous circulatory failure. One major feature is profound hypotension. The blood pressure becomes too low to maintain organ perfusion. The kidneys are highly sensitive to reduced blood flow. In this patient, kidney function changes rapidly. His baseline serum creatinine was 1 mg per deciliter. Within 24 hours, it increased to 2.5 mg per deciliter. This significant rise suggests acute kidney injury. His urine output also decreased. He produced less than 20 milliliters of urine per hour. Low urine output is called oliguria. Using KDIGO criteria, this patient meets stage 2 acute kidney injury. The main question is, why did this patient develop kidney injury? The answer is reduced renal perfusion. In septic shock, widespread inflammation causes systemic vasodilation. Blood vessels throughout the body become excessively relaxed. Blood pressure falls. The kidneys receive less effective blood flow. This causes severe renal hypoperfusion. The glomerulus receives less pressure for filtration. As a result, glomerular filtration rate decreases. The kidneys cannot remove waste efficiently. This causes creatinine levels to rise. Importantly, the kidney tissue is initially not structurally damaged. The problem is mainly reduced blood supply. This explains why prerenal acute kidney injury can improve if circulation is restored quickly. Laboratory findings can help identify the mechanism. One useful marker is the blood urea nitrogen BUN to creatinine ratio. In prerenal acute kidney injury, the ratio is often greater than 20:1. This happens because the kidney tries to conserve water. It increases urea reabsorption. Another important marker is the fractional excretion of sodium. In prerenal acute kidney injury, fractional excretion of sodium is usually less than 1%. This shows that the kidney is actively retaining sodium. The tubules are still functioning. Urine microscopy may show hyaline casts. Hyaline casts are formed from proteins in concentrated urine. They are commonly seen when the kidney is conserving fluid. This case highlights an important principle. Severe infection can damage kidney function without directly attacking kidney tissue. The main problem is circulation. Early recognition and treatment of sepsis are essential. Restoring blood pressure and kidney perfusion can prevent progression. However, if poor perfusion continues, prerenal acute kidney injury can progress to intrinsic injury. Understanding the mechanism helps guide treatment and improve outcomes. Now let us examine another clinical example of acute kidney injury. This case demonstrates drug-induced acute tubular necrosis. Our patient is Mr. John. He was initially treated for a serious infection. Because of the severity of his illness, he received high-dose gentamicin. Gentamicin is an aminoglycoside antibiotic. It is effective against many serious bacterial infections. However, it has an important adverse effect. It can cause direct kidney tubular injury. Initially, Mr. John had low blood pressure from infection. After treatment, his blood pressure stabilized. However, several days later, his kidney function worsened. His serum creatinine increased to 3.5 mg per deciliter. This suggests a new cause of kidney injury. The question is, why did kidney function continue to decline despite improved circulation? The answer is nephrotoxic acute tubular necrosis. Gentamicin accumulates inside proximal tubular cells. It collects within lysosomes and mitochondria. Inside these cells, it causes oxidative stress. Oxidative stress damages cellular structures. Mitochondria become impaired. Energy production decreases. ATP levels fall. Without enough energy, tubular cells cannot function normally. Eventually, the cells become injured and die. This is called tubular necrosis. The kidney injury is now structural. This is different from prerenal acute kidney injury. In prerenal acute kidney injury, the kidney is trying to conserve sodium. In acute tubular necrosis, the damaged tubules lose this ability. This difference appears in laboratory findings. The fractional excretion of sodium, or FENa, increases. In acute tubular necrosis, fractional excretion of sodium is often greater than 2%. The injured tubules cannot effectively reabsorb sodium. Urine microscopy also provides important clues. A classic finding is dirty brown, granular casts. These casts contain damaged tubular cells and proteins. They are a sign of tubular injury. Modern biomarkers can detect injury earlier. Examples include NGAL and KIM1. NGAL rises when tubular cells are injured. KIM1 is another marker of tubular damage. These biomarkers may detect kidney stress before creatinine rises significantly. This case teaches an important lesson. Not all acute kidney injury after infection is caused by low blood pressure. medications can directly damage kidney structures. Gentamicin remains a valuable antibiotic. However, careful dosing and kidney monitoring are essential. Risk increases with high doses, prolonged therapy, and existing kidney problems. Understanding the mechanism allows clinicians to balance effective treatment with kidney protection. When a patient develops acute kidney injury, or AKI, drug absorption can become much less predictable. Many people think the kidneys only affect drug elimination, but acute kidney injury can also significantly influence what happens before a drug even enters the bloodstream. One important change is reduced gastrointestinal motility. In acute kidney injury, the accumulation of uremic toxins can slow the movement of the stomach and intestines. This condition, often called gastric stasis, causes delayed gastric emptying. As a result, oral medications may remain in the stomach longer than expected before reaching the small intestine, where most drug absorption occurs. This can delay the onset of action and make drug responses less predictable. Another major factor is tissue edema. Patients with acute kidney injury frequently experience fluid retention. Excess fluid can accumulate within the bowel wall, causing intestinal edema. When the intestinal lining becomes swollen, drugs have a more difficult time crossing from the gut into the bloodstream. This impaired transmucosal transport can reduce the amount of drug absorbed and may lead to lower than expected drug concentrations. Changes in gastric pH also play an important role. Uremia can alter normal gastric acid secretion, often resulting in a higher gastric pH. This means the stomach becomes less acidic than usual. Some medications, especially weak acids, rely on an acidic environment to dissolve efficiently. When gastric acidity decreases, dissolution may be impaired, slowing or reducing absorption. In contrast, the absorption of certain other drugs may be enhanced or altered in unpredictable ways. These physiological changes rarely occur in isolation. A patient with acute kidney injury may simultaneously experience delayed gastric emptying, bowel wall edema, and altered gastric pH. Together, these factors create substantial variability in oral drug absorption. Even when the correct dose is administered, the amount of drug that actually reaches the systemic circulation may differ significantly from one patient to another. The overall effect is decreased and erratic oral drug absorption. Some medications may be absorbed more slowly, others less completely, and some may show highly variable bioavailability. This unpredictability can make therapeutic drug monitoring especially important in critically ill patients with acute kidney injury. For clinicians, the key message is simple. Acute kidney injury affects much more than renal drug clearance. It can also disrupt the absorption phase of pharmacokinetics, making oral drug therapy less reliable. Understanding these changes helps optimize medication selection, dosing strategies, and patient outcomes in individuals with impaired kidney function. Acute kidney injury, or AKI, can dramatically alter how drugs are distributed throughout the body. Even when the prescribed dose remains unchanged, the concentration of active drug reaching tissues may be very different from what clinicians expect. One of the most important changes involves the volume of distribution, often abbreviated as VD. This pharmacokinetic parameter describes how extensively a drug spreads from the bloodstream into body tissues. In patients with acute kidney injury, severe fluid retention is common. Excess fluid accumulates within the vascular space and tissues, creating a larger compartment into which drugs can distribute. This effect is particularly important for hydrophilic, or water-soluble, medications. Examples include many beta-lactam antibiotics. Because these drugs preferentially remain within body water, fluid overload can significantly increase their volume of distribution. As a result, the initial drug concentration in the bloodstream may be lower than expected, potentially reducing therapeutic effectiveness if dosing adjustments are not considered. Acute kidney injury also affects protein binding. Under normal circumstances, many drugs bind to plasma proteins, especially albumin. Only the unbound, or free, portion of a drug is pharmacologically active and able to reach target tissues. The bound fraction essentially acts as a temporary reservoir within the circulation. In acute kidney injury, uremic toxins accumulate in the bloodstream as kidney function declines. These toxins compete with medications for albumin binding sites. When binding sites become occupied by uremic compounds, drugs that normally attach to albumin can be displaced into the circulation as free drug. This phenomenon is especially important for highly protein-bound medications such as phenytoin and warfarin. Even if laboratory measurements show a normal total drug concentration, the amount of free, active drug may be substantially higher than expected. This means the patient can experience enhanced pharmacologic effects despite receiving a standard dose. For phenytoin, increased free drug levels can raise the risk of adverse neurological effects such as nystagmus, ataxia, confusion, or excessive sedation. For warfarin, displacement from albumin can increase anticoagulant activity and elevate the risk of bleeding complications. These changes in distribution and protein binding often occur simultaneously. Fluid overload may alter where a drug goes, while reduced protein binding increases the proportion that remains pharmacologically active. Together, these alterations can make drug behavior highly unpredictable. The overall effect is an increase in the free, active fraction of many medications and a greater risk of drug toxicity. For clinicians, this highlights the importance of careful dose selection, close monitoring, and interpretation of drug levels in the context of kidney function. In acute kidney injury, understanding distribution and protein binding is essential for maximizing therapeutic benefit while minimizing harm. Acute kidney injury, or AKI, affects much more than the kidneys. One of the most fascinating and clinically important concepts is the close relationship between the kidneys and the liver. This interaction is often referred to as liver-kidney crosstalk. Many clinicians assume that if a drug is primarily metabolized by the liver, kidney dysfunction will have little effect on its pharmacokinetics. However, severe acute kidney injury can significantly alter hepatic drug metabolism, making this assumption potentially dangerous. As kidney function declines, uremic toxins begin to accumulate in the bloodstream. These toxins do not remain confined to the kidneys. Instead, they circulate throughout the body and can interfere with the function of other organs, including the liver. The result is a reduction in the liver's ability to metabolize medications efficiently. One major target of this effect is the cytochrome P450 enzyme system, commonly known as CYP450. These enzymes are responsible for the phase 1 metabolism of many drugs. Phase 1 reactions typically involve oxidation, reduction, or hydrolysis, transforming medications into more water-soluble compounds that can be eliminated from the body. In patients with severe acute kidney injury, accumulated uremic toxins can suppress CYP450 enzyme activity. This means drugs that normally undergo rapid hepatic metabolism may be processed much more slowly. Consequently, drug concentrations can remain elevated for longer periods, increasing the likelihood of adverse effects. The impact is not limited to phase 1 metabolism. Uremia can also impair phase 2 metabolic pathways. These reactions include conjugation processes such as glucuronidation, sulfation, and acetylation. Phase 2 metabolism is essential for the detoxification and elimination of many medications and their metabolites. When these pathways are down-regulated, drug clearance may be further reduced. The clinical consequences can be significant. Medications traditionally considered to be almost exclusively cleared by the liver may exhibit prolonged half-lives in patients with severe renal dysfunction. In other words, the drug remains in the body much longer than expected, even though hepatic metabolism is its primary route of elimination. This can lead to gradual drug accumulation during repeated dosing. A regimen that appears appropriate on paper may eventually produce unexpectedly high drug concentrations and increase the risk of toxicity. The key takeaway is that acute kidney injury is a systemic condition, not simply a kidney problem. Through liver-kidney crosstalk, uremic toxins can suppress both phase 1 and phase 2 hepatic metabolism. As a result, drugs presumed to be exclusively hepatically cleared may have reduced clearance and prolonged half-lives. Understanding this relationship is essential for safe prescribing, appropriate dose adjustments, and effective therapeutic monitoring in patients with acute kidney injury. Acute kidney injury, or AKI, has its most dramatic pharmacokinetic effects on drug elimination. The kidneys are responsible for removing many medications and their metabolites from the body. When kidney function suddenly declines, this elimination process can slow dramatically, causing drugs to accumulate to potentially dangerous levels. Under normal circumstances, the kidneys continuously filter blood, excrete waste products, and remove medications through urine. In acute kidney injury, this filtration process is severely impaired. As a result, drugs that depend on renal clearance remain in the circulation much longer than intended. This reduction in renal clearance often requires immediate dose adjustment. Continuing standard doses in a patient with significant acute kidney injury can rapidly lead to drug accumulation and toxicity. Medications commonly affected include digoxin and many antibiotics. Without appropriate dose modification, drug concentrations may rise above the therapeutic range and cause serious adverse effects. Digoxin provides a classic example. Because it is primarily eliminated by the kidneys, impaired renal function can cause plasma concentrations to increase significantly. Excessive digoxin levels may lead to nausea, vomiting, visual disturbances, confusion, and potentially life-threatening cardiac arrhythmias. Many antibiotics are also heavily dependent on renal excretion. If doses are not adjusted appropriately, excessive drug exposure can increase the risk of toxicity while complicating patient management. This is why renal dosing is such a critical component of pharmacotherapy in acute kidney injury. An equally important but often overlooked issue is the accumulation of active drug metabolites. In some cases, the parent drug may not be the primary problem. Instead, metabolites that are normally eliminated by the kidneys begin to build up in the body and produce toxic effects. Meperidine is a well-known example. This opioid analgesic is metabolized to normeperidine, an active metabolite that is normally cleared by the kidneys. In patients with acute kidney injury, normeperidine can accumulate to dangerous levels. Unlike the parent drug, this metabolite has significant neurotoxic properties. Patients may develop agitation, tremors, muscle twitching, and, in severe cases, seizures. Morphine provides another important example. It is metabolized to morphine-6-glucuronide, an active metabolite with potent opioid activity. When kidney function is impaired, This metabolite can accumulate progressively. Even when the morphine dose appears reasonable, rising levels of morphine 6-glucuronate can cause profound sedation and severe respiratory depression. This may result in dangerously slow breathing and potentially life-threatening respiratory failure. The key message is that acute kidney injury affects not only the elimination of parent drugs, but also the clearance of active metabolites. Reduced renal clearance can dramatically prolong drug exposure, while metabolite accumulation may create unexpected toxicities. Understanding these pharmacokinetic changes is essential for selecting appropriate medications, adjusting doses promptly, and protecting patients from preventable adverse drug reactions during acute kidney injury. Acute kidney injury, or AKI, does not only change how the body handles drugs. It also changes how the body responds to them. These changes are known as pharmacodynamic alterations, and they can make patients far more sensitive to medication effects than expected. One major reason is the development of electrolyte abnormalities. The kidneys play a critical role in maintaining normal electrolyte balance, and when they fail, significant disturbances can occur. Among the most important is hyperkalemia, or elevated potassium levels. Hyperkalemia can have profound effects on the heart. In patients receiving digoxin, high potassium levels can worsen the toxic effects of the drug. Even digoxin concentrations that would normally be tolerated may become dangerous when severe hyperkalemia is present. The combination can increase the risk of conduction abnormalities, arrhythmias, and potentially life-threatening cardiac events. Hypercalcemia is another common electrolyte disturbance in acute kidney injury. Calcium plays a vital role in cardiac muscle contraction and electrical conduction. When calcium levels fall, the electrical properties of the heart change. Cardiac excitation thresholds may be altered, making the heart more susceptible to rhythm disturbances and modifying the way certain cardiovascular drugs exert their effects. The central nervous system is also significantly affected by acute kidney injury. As uremic toxins accumulate, they can disrupt the integrity of the blood-brain barrier. Under normal conditions, this barrier acts as a protective filter, limiting the entry of potentially harmful substances into the brain. In uremia, however, the barrier becomes more permeable. This increased permeability allows greater exposure of the brain to circulating drugs and toxins. As a result, medications that act on the central nervous system may produce exaggerated effects even at standard doses. A dose that would normally provide mild sedation may suddenly cause profound drowsiness or impaired consciousness. Opioids are particularly affected by these changes. Patients with acute kidney injury often experience enhanced sensitivity to opioid analgesics. Sedation can become more pronounced, and the risk of respiratory depression increases substantially. Careful dose selection and close monitoring are therefore essential. Benzodiazepines can also produce exaggerated responses. Medications used for anxiety, procedural sedation, or seizure control may cause excessive drowsiness, confusion, prolonged sedation, or impaired coordination in patients with significant renal dysfunction. Other sedative medications show similar patterns. Because the brain becomes more vulnerable in the setting of uremia, even routine doses can lead to unexpectedly strong pharmacologic effects. The overall message is clear. In acute kidney injury, pharmacodynamic changes can make patients far more sensitive to medications than anticipated. Electrolyte disturbances alter cardiac responses, while uremia increases blood-brain barrier permeability and enhances central nervous system drug effects. Understanding these changes helps clinicians anticipate toxicity, individualize therapy, and improve medication safety in patients with acute kidney injury. One of the most frustrating challenges in managing acute kidney injury, or AKI, is diuretic resistance. Clinicians often administer loop diuretics expecting increased urine output, only to find that the patient remains fluid overloaded despite treatment. Understanding why this happens is essential for effective patient care. Loop diuretics, such as furosemide, work by blocking sodium and chloride reabsorption in a specific segment of the kidney known as the thick ascending limb of the loop of Henle. For these drugs to work, they must first reach their site of action within the tubular lumen. In severe acute kidney injury, several factors interfere with this process. The first mechanism involves reduced renal blood flow. In many patients with acute kidney injury, kidney perfusion is significantly diminished. Because less blood reaches the kidneys, less diuretic is delivered to the nephrons. Even when an adequate dose is administered, insufficient drug may arrive at the target site to produce the desired diuretic effect. The second mechanism involves competition from uremic toxins. Loop diuretics are not primarily filtered into the urine. Instead, they rely on active secretion through organic anion transporters, commonly called OATs, located in the proximal tubule. These transporters act like specialized delivery systems that move the drug from the bloodstream into the tubular fluid. In acute kidney injury, uremic toxins accumulate in large quantities. These toxins compete with loop diuretics for access to the same transporters. As a result, less drug is secreted into the tubular lumen. Even though the medication is present in the bloodstream, it may never reach sufficient concentrations at its site of action inside the nephron. The third mechanism becomes especially important in acute tubular necrosis, or ATN, a common cause of severe acute kidney injury. In acute tubular necrosis, the tubular cells themselves are injured and dysfunctional. Even when the diuretic successfully reaches the tubular lumen, the damaged nephron may respond poorly to the drug's pharmacologic action. In other words, the medication arrives at its destination, but the target tissue is no longer functioning normally. The expected blockade of sodium reabsorption becomes less effective, and urine output may remain disappointingly low. These mechanisms often occur simultaneously. Reduced blood flow limits delivery, uremic toxins impair secretion, and tubular injury decreases responsiveness. Together, they create a perfect environment for diuretic resistance. The clinical consequence is persistent fluid overload despite escalating doses of loop diuretics. Patients may continue to experience edema, pulmonary congestion, and worsening respiratory symptoms. In some cases, alternative strategies such as combination diuretic therapy, optimization of hemodynamics, or kidney replacement therapy may become necessary. The key takeaway is that diuretic resistance in acute kidney injury is not simply a matter of giving a higher dose. It reflects complex pharmacodynamic changes involving impaired drug delivery, transporter competition, and damaged tubular function. Understanding these mechanisms helps clinicians make better treatment decisions and manage fluid overload more effectively. Chronic kidney disease, commonly known as CKD, is a long-term condition in which the kidneys gradually lose their ability to function normally. Unlike acute kidney injury, which develops suddenly over hours or days, chronic kidney disease evolves slowly over months or years. Because the progression is often gradual, many patients may not notice symptoms until significant kidney damage has already occurred. Chronic kidney disease is defined as abnormalities in kidney structure or function that persist for at least 3 months. These abnormalities may include a reduced glomerular filtration rate, the presence of protein in the urine, structural changes seen on imaging studies, or other markers indicating ongoing kidney damage. The key feature is persistence. Temporary changes in kidney function do not qualify as chronic kidney disease unless they continue for 3 months or longer. One of the most important characteristics of chronic kidney disease is its progressive nature. In many patients, kidney function declines gradually over time. As healthy nephrons are lost, the remaining nephrons work harder to compensate. Although this adaptation helps maintain kidney function initially, it can eventually accelerate further damage. This creates a cycle of ongoing nephron loss and progressive decline in renal function. Chronic kidney disease is generally considered irreversible. Once significant kidney tissue has been damaged or lost, it usually cannot regenerate. For this reason, early detection and intervention are critical. The goal of treatment is often not to reverse the disease, but to slow its progression, preserve remaining kidney function, and reduce complications. The 2 most common causes of chronic kidney disease worldwide are diabetes mellitus and hypertension. Together, they account for the majority of cases seen in clinical practice. In diabetes mellitus, persistently elevated blood glucose levels damage the small blood vessels within the kidneys. Over time, this injury affects the filtering units known as glomeruli, leading to diabetic kidney disease. Protein may begin to leak into the urine, and kidney function gradually deteriorates. Hypertension, or high blood pressure, is another major contributor. Elevated pressure within blood vessels places continuous stress on the delicate renal circulation. Over many years, this damage causes scarring and narrowing of renal blood vessels, reducing blood flow and impairing kidney function. The relationship between chronic kidney disease and these conditions is often bidirectional. Kidney disease can worsen hypertension, while poorly controlled hypertension accelerates kidney damage. Similarly, uncontrolled diabetes increases the risk of progressive renal decline. The key message is simple. Chronic kidney disease is a persistent abnormality of kidney structure or function lasting at least 3 months. It is typically progressive, often irreversible, and most commonly driven by diabetes mellitus and hypertension. Early recognition, careful monitoring, and effective management of these underlying conditions are essential for preserving kidney health and improving long-term patient outcomes. Understanding the stages of chronic kidney disease, or CKD, is essential for assessing disease severity and guiding treatment decisions. The most commonly used system is based on the glomerular filtration rate, or GFR. Glomerular filtration rate estimates how much blood the kidneys filter each minute and serves as one of the best indicators of overall kidney function. The higher the glomerular filtration rate, the better the kidneys are functioning. As kidney disease progresses, the glomerular filtration rate gradually declines, reflecting a loss of filtering capacity. Stage G1 represents a glomerular filtration rate of 90 milliliters per minute or higher. This range is considered normal or high kidney function. However, a person can still have chronic kidney disease at this stage if there is evidence of kidney damage, such as protein in the urine, structural abnormalities, or persistent kidney injury markers. In other words, a normal glomerular filtration rate does not always mean the kidneys are completely healthy. Stage G2 includes a glomerular filtration rate between 60 and 89 milliliters per minute. Kidney function is mildly decreased, but many patients remain asymptomatic. At this stage, the kidneys are still able to perform most of their essential functions effectively. Nevertheless, ongoing kidney damage may continue silently, making regular monitoring extremely important. As chronic kidney disease progresses, Patients enter stage G3, which is divided into G3A and G3B. This stage corresponds to a glomerular filtration rate between 30 and 59 milliliters per minute. Kidney function is now moderately reduced. Waste products begin to accumulate more noticeably, and complications such as anemia, hypertension, and early mineral and bone disorders may start to develop. Dividing stage G3 into G3A and G3B helps clinicians better estimate risk and tailor management strategies. Stage G4 is characterized by a glomerular filtration rate between 15 and 29 milliliters per minute. At this point, kidney function is severely decreased. The kidneys struggle to maintain normal fluid, electrolyte, and metabolic balance. Symptoms such as fatigue, swelling, loss of appetite, and difficulty concentrating may become more apparent. Patients in this stage often require close follow-up and preparation for possible kidney replacement therapy. Stage G5 represents the most advanced form of chronic kidney disease. The glomerular filtration rate falls below 15 milliliters per minute, indicating kidney failure. This stage is commonly referred to as end-stage renal disease, or ESRD. The kidneys can no longer adequately remove waste products or regulate fluid balance. Without treatment, dangerous complications can develop. Many patients at this stage require dialysis or kidney transplantation to sustain life. It is important to remember that chronic kidney disease staging is more than just assigning a number. Each stage reflects a progressive decline in kidney function and an increasing risk of complications. Early identification of declining glomerular filtration rate allows healthcare providers to implement interventions that may slow disease progression and improve long-term outcomes. The key message is simple. As glomerular filtration rate decreases from G1 to G5, kidney function progressively worsens, and the need for closer monitoring, complication management, and advanced treatment strategies becomes increasingly important. When evaluating chronic kidney disease, or CKD, healthcare professionals look at more than just the glomerular filtration rate, or GFR. Another critical marker is albuminuria, which measures how much albumin is leaking into the urine. Albumin is a protein that normally remains in the bloodstream. Healthy kidneys prevent significant amounts of albumin from passing into the urine. To assess albuminuria, clinicians commonly use the albumin to creatinine ratio, or ACR. This test measures the amount of albumin relative to creatinine in a urine sample. Using creatinine helps account for differences in urine concentration, making the result more reliable and easier to interpret. The albumin to creatinine ratio provides valuable information about the extent of kidney damage. Even when glomerular filtration rate appears relatively preserved, increased albumin excretion may indicate ongoing injury to the kidney's filtering units, known as glomeruli. The first category is A1. This corresponds to an albumin to creatinine ratio of less than 30 milligrams per gram. This range is considered normal to mildly increased. Very little albumin is leaking into the urine, suggesting that the kidney's filtration barrier remains largely intact. Patients in this category generally have a lower risk of disease progression, although other factors must still be considered. The second category is A2, with an albumin to creatinine ratio between 30 and 300 milligrams per gram. This level is described as moderately increased albuminuria. In the past, it was often called microalbuminuria. At this stage, the kidneys are allowing more albumin to escape into the urine, indicating early but clinically important kidney damage. Detecting A2 albuminuria is especially important because it often represents one of the earliest signs of diabetic kidney disease and hypertensive kidney injury. The third category is A3, defined by an albumin to creatinine ratio greater than 300 mg per gram. This is known as severely increased albuminuria. Previously, it was referred to as macroalbuminuria. At this level, substantial amounts of albumin are being lost in the urine, reflecting significant glomerular injury. Patients with A3 albuminuria are at much higher risk of progressive kidney dysfunction and long-term complications. The significance of albuminuria extends far beyond the kidneys. Numerous studies have shown that higher albumin to creatinine ratio values are strongly associated with faster chronic kidney disease progression. The more albumin that leaks into the urine, the greater the likelihood that kidney function will continue to decline over time. Albuminuria is also an important cardiovascular risk marker. Patients with elevated albumin to creatinine ratio have a higher risk of heart attacks, strokes, heart failure, and cardiovascular death. In many ways, albuminuria serves as a warning sign of widespread vascular damage throughout the body. The key message is simple. The albumin to creatinine ratio helps measure kidney damage and predict future risk. As albumin to creatinine ratio rises from A1 to A3, the likelihood of chronic kidney disease progression and cardiovascular complications increases significantly. That is why albuminuria assessment is a cornerstone of modern chronic kidney disease evaluation and management. To understand why chronic kidney disease, or CKD, continues to worsen over time, we need to explore one of the most important concepts in nephrology, the hyperfiltration hypothesis. This theory helps explain why kidney damage often progresses even after the original cause has been treated or brought under control. The process usually begins with an initial injury to the kidneys. This injury may result from conditions such as diabetes mellitus, hypertension, glomerulonephritis, or other kidney diseases. Whatever the cause, the damage leads to the loss of functioning nephrons. Remember, nephrons are the microscopic filtering units that perform the essential work of the kidneys. At first, the body attempts to compensate for this loss. The remaining healthy nephrons work harder to maintain overall kidney function. This adaptive response is known as compensatory hypertrophy. The surviving nephrons become larger and increase their filtering activity in an effort to replace the function of the damaged nephrons. Initially, this compensation appears beneficial. Kidney function may remain relatively stable despite substantial nephron loss. However, this adaptation comes at a cost. As the surviving nephrons increase their workload, pressure within the glomeruli begins to rise. The glomerulus is the tiny network of capillaries responsible for filtering blood. Increased intraglomerular pressure forces more blood through these delicate structures, resulting in a state of hyperfiltration. At the same time, the increased flow generates greater mechanical stress on the glomerular capillaries. This phenomenon is often referred to as shear stress. Over months and years, the constant exposure to elevated pressure and mechanical strain damages the glomerular filtration barrier. Eventually, this ongoing injury leads to glomerulosclerosis. The term refers to scarring and hardening of the glomeruli. Once a glomerulus becomes scarred, it loses its ability to filter blood effectively. As more glomeruli are damaged, additional nephrons are lost. This creates a self-perpetuating cycle. Nephron loss forces the remaining nephrons to work even harder. Increased workload causes more hyperfiltration and higher intraglomerular pressure. That pressure causes further scarring, which leads to even more nephron loss. The most important point is that this cycle can continue independently of the original disease. For example, a patient may achieve excellent blood pressure control after years of hypertension. However, if significant nephron loss has already occurred, hyperfiltration injury may persist and continue driving chronic kidney disease progression. This is why early intervention is so critical. Treatments such as blood pressure control, glucose management, and medications that reduce intraglomerular pressure aim to interrupt this destructive cycle before irreversible damage becomes extensive. The key message is simple. Chronic kidney disease progression is often driven by hyperfiltration. Initial nephron loss triggers compensation by surviving nephrons, but the resulting increase in pressure and stress eventually causes further scarring and nephron death. This vicious cycle can continue for years, gradually leading to worsening kidney function and, ultimately, kidney failure. Diabetic kidney disease, often called DKD, is one of the most common causes of chronic kidney disease worldwide. It develops gradually as a result of long-standing diabetes mellitus and is a major contributor to kidney failure, cardiovascular disease, and premature mortality. The process begins with chronic hyperglycemia, or persistently elevated blood glucose levels. When glucose remains high for prolonged periods, it undergoes a process known as non-enzymatic glycation. In simple terms, glucose molecules attach to proteins and other structures without the help of enzymes. Over time, these glycated products accumulate within the kidneys and cause progressive damage. One of the primary targets is the glomerular basement membrane, or GBM. The glomerular basement membrane is a critical component of the kidney's filtration barrier. Its normal function is to allow waste products and excess fluid to pass into the urine while retaining important proteins in the bloodstream. As glycation progresses, the glomerular basement membrane becomes abnormally thickened. Although a thicker membrane may sound protective, it actually impairs normal filtration and contributes to ongoing kidney injury. The filtration barrier becomes less efficient and more susceptible to protein leakage. Another important change involves podocytes. These specialized cells wrap around the glomerular capillaries and play a key role in preventing protein loss. Chronic exposure to high glucose levels damages podocytes, causing them to lose their normal structure and function. Once podocytes are injured or lost, the filtration barrier becomes increasingly permeable. At the same time, the mesangium undergoes expansion. Mesangial cells and matrix provide structural support within the glomerulus. In diabetic kidney disease, excess matrix material accumulates, causing mesangial expansion and contributing to glomerular scarring. This further reduces the kidney's ability to filter blood effectively. These structural changes do not occur overnight. They develop gradually over years of uncontrolled or poorly controlled diabetes. As damage progresses, one of the earliest and most important clinical signs is albuminuria. Albuminuria occurs when albumin, a protein that should remain in the bloodstream, leaks into the urine. Initially, the amount may be small, but over time urinary albumin excretion often increases. Progressive albuminuria serves as a warning sign that diabetic kidney damage is advancing. Fortunately, several pharmacological strategies can slow disease progression. One of the most important targets is the renin-angiotensin-aldosterone system, or RAAS. Medications such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, known as angiotensin II receptor blockers, reduce pressure within the glomerulus. By lowering intraglomerular pressure, these drugs help decrease protein leakage and protect remaining kidney function. More recently, SGLT2 inhibitors have transformed the management of diabetic kidney disease. These medications not only improve glucose control but also reduce intraglomerular pressure and slow chronic kidney disease progression. They have demonstrated significant benefits for both kidney and cardiovascular outcomes. The key message is simple. Chronic hyperglycemia damages the glomerular filtration barrier through glycation, podocyte injury, and mesangial expansion. This leads to progressive albuminuria and declining kidney function. Early treatment with renin-angiotensin-aldosterone system inhibitors and SGLT2 inhibitors can significantly slow disease progression and preserve kidney health. Hypertensive nephropathy is a form of chronic kidney disease caused by long-standing high blood pressure. It is one of the leading causes of kidney failure worldwide and often develops silently over many years. Because hypertension may produce few symptoms in its early stages, significant kidney damage can occur before the condition is recognized. The kidneys contain thousands of tiny blood vessels that continuously filter blood and maintain fluid and electrolyte balance. These delicate structures are designed to function within a relatively narrow pressure range. When blood pressure remains elevated for years, the kidneys are exposed to excessive mechanical stress. The fundamental mechanism is direct barotrauma. In simple terms, high systemic arterial pressure is transmitted to the glomeruli, the microscopic filtering units of the kidneys. The glomerular capillaries are extremely delicate, and prolonged exposure to increased pressure gradually damages their walls. Initially, the kidneys attempt to protect themselves by altering vascular tone and blood flow. However, persistent hypertension eventually overwhelms these protective mechanisms. The result is progressive injury to both the glomeruli and the renal blood vessels. One of the hallmark pathological changes is arteriosclerosis. This refers to thickening, stiffening, and hardening of the small arteries and arterioles supplying the kidneys. Over time, the vessel walls become less elastic and the internal lumen becomes progressively narrower. As these vessels narrow, blood flow to kidney tissue decreases. This reduction in perfusion limits the delivery of oxygen and nutrients to the nephrons. Although the process develops slowly, the cumulative effect can be substantial. The kidneys are highly metabolically active organs and require a constant oxygen supply to function properly. When blood flow is chronically reduced, kidney tissue experiences ongoing ischemia. Ischemia simply means inadequate oxygen delivery to meet metabolic demands. Chronic ischemia causes progressive injury to the tubules and surrounding interstitial tissue. Over time, normal kidney tissue is replaced by scar tissue through a process known as fibrosis. This scarring is particularly prominent within the tubulo-interstitial compartment, which includes the renal tubules and the supportive tissue surrounding them. As tubulo-interstitial fibrosis becomes more extensive, kidney function gradually declines. The affected nephrons lose their ability to effectively filter blood, regulate fluid balance, and maintain normal electrolyte homeostasis. This loss of functioning nephrons further accelerates chronic kidney disease progression. The relationship between hypertension and kidney disease is often a vicious cycle. High blood pressure damages the kidneys, and declining kidney function can further worsen hypertension. This creates a self-perpetuating process that may continue unless aggressive intervention occurs. The key message is simple. In hypertensive nephropathy, persistent high blood pressure causes direct injury to glomeruli and renal blood vessels. Arteriosclerosis narrows the renal circulation, reducing oxygen delivery to kidney tissue. The resulting chronic ischemia promotes severe tubulo-interstitial fibrosis, progressive nephron loss, and declining kidney function. Early blood pressure control is therefore one of the most effective strategies for preserving long-term renal health and preventing chronic kidney disease progression. As chronic kidney disease progresses, the kidneys gradually lose their ability to maintain normal fluid, electrolyte, and metabolic balance. These disturbances become particularly severe in advanced stages of kidney disease and contribute significantly to patient symptoms and complications. One of the earliest and most important problems is fluid overload. Healthy kidneys continuously adjust the excretion of sodium and water to match the body's needs. In advanced chronic kidney disease, this regulatory function becomes impaired. Sodium and water begin to accumulate within the body because the kidneys can no longer eliminate them efficiently. The result is fluid retention. Patients may notice swelling of the feet, ankles, legs, or even the face. This swelling is known as edema. As fluid accumulation worsens, excess fluid can also enter the lungs, making breathing more difficult. In susceptible individuals, persistent fluid overload can place additional strain on the heart and contribute to the development or worsening of heart failure. Another major complication is hyperkalemia, which refers to elevated potassium levels in the bloodstream. Under normal circumstances, the kidneys are the primary route for potassium elimination. When kidney function declines, potassium excretion decreases and serum potassium levels begin to rise. Hyperkalemia is particularly concerning because potassium plays a critical role in cardiac electrical activity. Excessively high potassium levels can disrupt normal heart rhythms and may lead to life-threatening arrhythmias. The risk may be further increased by medications such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, which are commonly used to protect kidney function, but can also reduce potassium excretion. Metabolic acidosis is another hallmark of advanced kidney disease. The kidneys normally help maintain acid-base balance by excreting hydrogen ions and reclaiming bicarbonate. Specialized cells known as intercalated cells perform much of this work within the nephron. As chronic kidney disease progresses, these mechanisms become less effective. Hydrogen ions accumulate while bicarbonate levels decline. The resulting metabolic acidosis can contribute to muscle weakness, fatigue, bone disease, inflammation, and accelerated progression of kidney dysfunction. When kidney failure becomes severe, patients may develop uremic syndrome. This condition is most commonly seen in stage G5 chronic kidney disease, when kidney function is profoundly reduced and waste products accumulate throughout the body. Uremia affects multiple organ systems. Patients often experience persistent fatigue because toxins interfere with normal cellular function. Nausea and loss of appetite are common and may contribute to weight loss and poor nutritional status. Many individuals develop pruritus, or persistent itching, which can significantly reduce quality of life. Uremic toxins may also damage peripheral nerves, leading to neuropathy. Patients may describe numbness, tingling, burning sensations, or weakness in the hands and feet. As toxin levels continue to rise, the brain can also be affected. Altered mental status may develop, ranging from difficulty concentrating and memory problems to confusion and, in severe cases, reduced consciousness. The key message is simple. Advanced chronic kidney disease disrupts fluid balance, electrolyte regulation, and acid-base homeostasis. Fluid overload, hyperkalemia, metabolic acidosis, and uremic syndrome are major consequences of declining kidney function and often signal the need for intensive management or kidney replacement therapy. One of the most common and clinically significant complications of chronic kidney disease, or CKD, is anemia. As kidney function declines, many patients experience a gradual reduction in their red blood cell count. This can lead to fatigue, weakness, reduced exercise tolerance, shortness of breath, and a noticeable decline in quality of life. The primary cause of anemia in chronic kidney disease is a deficiency of erythropoietin, commonly known as EPO. Erythropoietin is a hormone produced mainly by specialized interstitial fibroblasts within the kidneys. Its job is to signal the bone marrow to produce red blood cells. In healthy individuals, when oxygen levels fall, the kidneys respond by increasing erythropoietin production. This stimulates the bone marrow to generate more red blood cells and improve oxygen delivery throughout the body. In chronic kidney disease, however, progressive damage to the renal tissue destroys many of these erythropoietin-producing cells. As the number of functioning fibroblasts decreases, erythropoietin production falls. Without adequate erythropoietin stimulation, the bone marrow produces fewer red blood cells, resulting in anemia. Unfortunately, reduced erythropoietin production is only part of the problem. Several additional factors contribute to the development and persistence of anemia in chronic kidney disease. One important factor is chronic inflammation. Many patients with chronic kidney disease exist in a state of ongoing low-grade inflammation. Inflammatory signals stimulate the production of a hormone called hepcidin, which plays a key role in iron regulation. Elevated hepcidin levels reduce the absorption of dietary iron from the intestine and trap iron within storage sites in the body. As a result, iron may be present in the body but unavailable for effective red blood cell production. This phenomenon is often referred to as functional iron deficiency. True iron deficiency may also occur. Poor dietary intake, reduced gastrointestinal absorption, and chronic blood loss can further reduce iron stores. Since iron is an essential component of hemoglobin, inadequate iron availability limits the body's ability to produce healthy red blood cells. Another contributing factor is uremia. As waste products accumulate in advanced chronic kidney disease, they create an unfavorable environment for circulating red blood cells. Uremic toxins can damage red blood cell membranes and shorten their lifespan. Instead of surviving for their normal duration, red blood cells are removed from circulation more rapidly, worsening anemia. The combination of reduced erythropoietin production, impaired iron utilization, iron deficiency, and shortened red blood cell survival creates a multifactorial anemia that can be difficult to manage without targeted therapy. Treatment focuses on addressing these underlying mechanisms. Erythropoiesis-stimulating agents, or ESAs, mimic the action of natural erythropoietin and encourage the bone marrow to increase red blood cell production. Iron supplementation is often provided alongside erythropoiesis-stimulating agents to ensure that sufficient iron is available for hemoglobin synthesis and effective erythropoiesis. The key message is simple. Anemia of chronic kidney disease develops primarily because damaged kidneys produce less erythropoietin, but inflammation, iron disturbances, and uremia also contribute significantly. Effective treatment often requires both erythropoiesis-stimulating agents and iron replacement to improve oxygen delivery, reduce symptoms, and enhance patient well-being. One of the most important long-term complications of chronic kidney disease is CKD mineral and bone disorder, commonly known as CKD-MBD. This condition affects not only the bones, but also the blood vessels, heart, and overall health of patients with advanced kidney disease. The process begins as kidney function declines and the glomerular filtration rate, or GFR, falls. Healthy kidneys play a major role in removing excess phosphate from the body. As kidney function worsens, phosphate excretion becomes less efficient. Phosphate gradually accumulates in the bloodstream, leading to a condition known as hyperphosphatemia. At first, this rise in phosphate may not cause obvious symptoms. However, it triggers a cascade of hormonal and metabolic changes that disrupt the body's delicate balance of minerals. Another major problem is vitamin D deficiency. The kidneys are responsible for converting inactive vitamin D into its active form, called calcitriol. Calcitriol is essential for normal calcium absorption from the gastrointestinal tract. When the kidneys begin to fail, their ability to produce calcitriol declines. As a result, less calcium is absorbed from food. Over time, blood calcium levels start to fall, leading to hypercalcemia. The combination of high phosphate levels and low calcium levels is a powerful stimulus for the parathyroid glands. These small glands located behind the thyroid continuously monitor calcium concentrations in the bloodstream. When they detect low calcium and elevated phosphate, they respond by releasing large amounts of parathyroid hormone, or PTH. This compensatory response is known as secondary hyperparathyroidism because the excessive hormone production occurs as a consequence of chronic kidney disease rather than a primary disorder of the parathyroid glands. Initially, increased parathyroid hormone helps restore blood calcium levels. However, it achieves this by drawing calcium out of the bones. In effect, the skeleton becomes a mineral reservoir that the body uses to maintain normal blood calcium concentrations. Over time, persistent elevation of parathyroid hormone accelerates bone breakdown, a process known as bone resorption. The bones gradually lose strength and structural integrity. This condition, often referred to as renal osteodystrophy, can cause bone pain, skeletal deformities, muscle weakness, and an increased risk of fractures. The consequences extend beyond the skeleton. Excess phosphate and calcium may combine and deposit within blood vessel walls and soft tissues. This process is called vascular calcification. Vascular calcification causes blood vessels to become stiff and less flexible. As a result, cardiovascular disease risk increases substantially. In fact, cardiovascular complications are a leading cause of illness and death in patients with advanced chronic kidney disease. The key message is simple. As glomerular filtration rate declines, phosphate retention and reduced calcitriol production lead to hypercalcemia. These abnormalities stimulate secondary hyperparathyroidism, causing excessive bone resorption and renal osteodystrophy. At the same time, abnormal calcium phosphate balance promotes vascular calcification, linking kidney disease directly to both bone and cardiovascular complications. Let's apply what we have learned to a real-world clinical scenario. Meet Mrs. Sharma, a 70-year-old woman with a 20-year history of type 2 diabetes mellitus and hypertension. These two conditions are the leading causes of chronic kidney disease worldwide and place her at significant risk for progressive kidney damage. During routine follow-up, her laboratory results reveal an estimated glomerular filtration rate, or eGFR, of 45 milliliters per minute. Importantly, this value has remained consistently around the same level for the past 6 months. This detail is crucial. Chronic kidney disease is diagnosed when abnormalities of kidney structure or function persist for at least 3 months. Since Mrs. Sharma's reduced estimated glomerular filtration rate has been present for more than 6 months, she clearly meets the time requirement for a diagnosis of CKD. Next, we determine the glomerular filtration rate category. An estimated glomerular filtration rate of 45 milliliters per minute falls within the range of 45 to 59 milliliters per minute, which corresponds to stage G3A chronic kidney disease. This stage represents a moderate reduction in kidney function. At stage G3A, many patients may still feel relatively well, but important complications can begin to emerge. Careful monitoring becomes increasingly important because the risk of progression and cardiovascular disease starts to rise significantly. However, glomerular filtration rate is only part of the assessment. We must also evaluate albuminuria, which provides important information about the extent of kidney damage. Mrs. Sharma's urine albumin to creatinine ratio, or ACR, is consistently 350 mg per gram. This value exceeds 300 mg per gram, placing her in the A3 albuminuria category. A3 albuminuria indicates severely increased urinary albumin excretion. In older terminology, this level would have been called macroalbuminuria. It reflects substantial injury to the glomerular filtration barrier and is a strong marker of ongoing kidney damage. Combining both findings allows us to fully stage her disease. Her estimated glomerular filtration rate places her in G3A, while her albuminuria places her in A3. Therefore, her diagnosis is chronic kidney disease stage G3A, A3. This staging provides valuable prognostic information. Although her kidney function is only moderately reduced, the presence of severe albuminuria is particularly concerning. High levels of albumin leakage suggest active kidney injury and significantly increase the likelihood of further decline in renal function. In addition to predicting chronic kidney disease progression, A3 albuminuria is associated with a substantially increased risk of cardiovascular complications, including heart attacks, strokes, heart failure, and cardiovascular death. As a result, Mrs. Sharma's prognosis must be considered high risk. Her long-standing diabetes mellitus and hypertension continue to drive kidney injury, while severe albuminuria signals accelerated disease progression. The key message from this case is simple. Chronic kidney disease staging requires both estimated glomerular filtration rate and albuminuria assessment. Mrs. Sharma's persistent estimated glomerular filtration rate of 45 milliliters per minute classifies her as G3A, while her albumin to creatinine ratio of 350 mg per gram places her in A3. Together, these findings identify a patient at high risk for progressive kidney disease and future cardiovascular events. Let's continue Mrs. Sharma's journey and see how chronic kidney disease complications are managed in clinical practice. Over time, her kidney function declines further, and her estimated glomerular filtration rate, or eGFR, falls to 20 milliliters per minute. This places her in stage G4 chronic kidney disease, a stage characterized by severely reduced kidney function and a much higher risk of metabolic and systemic complications. New laboratory results reveal several important abnormalities. Her hemoglobin is 9 gams per deciliter, indicating significant anemia. Her phosphate level is elevated at 6.5 milligrams per deciliter, while her calcium level is low at 7.5 milligrams per deciliter. In addition, her C, or PTH, is markedly elevated at 400 picograms per milliliter. Together, these findings paint a classic picture of advanced chronic kidney disease with multiple complications requiring targeted therapy. Let's start with the anemia. As kidney function declines, the damaged kidneys produce less erythropoietin, or EPO, the hormone responsible for stimulating red blood cell production in the bone marrow. The result is a gradual decline in hemoglobin levels. Before initiating advanced anemia therapy, iron status must be addressed. Iron is an essential building block for hemoglobin synthesis. Even if the bone marrow receives stimulation, red blood cell production will remain inadequate if iron stores are insufficient. For this reason, iron therapy is typically initiated first. Once adequate iron availability has been ensured, an erythropoiesis-stimulating agent, or ESA, can be introduced. Erythropoiesis-stimulating agents mimic the action of natural erythropoietin and encourage the bone marrow to increase red blood cell production. This combination helps improve hemoglobin levels, reduce fatigue, and enhance quality of life. Next, consider her mineral and bone disorder. Her elevated phosphate level reflects the kidney's reduced ability to eliminate phosphorus. At the same time, low calcium and elevated chronic kidney disease indicates secondary hyperparathyroidism. One of the most important interventions is the use of oral phosphate binders. These medications are taken with meals because they work directly within the gastrointestinal tract. They bind dietary phosphate and reduce its absorption into the bloodstream. Lowering phosphate levels helps control secondary hyperparathyroidism and reduces the risk of bone disease and vascular calcification. Fluid overload is another common challenge in stage G4 chronic kidney disease. Many patients develop edema due to impaired sodium and water excretion. Swelling of the legs, ankles, and sometimes the lungs can significantly affect daily functioning and cardiovascular health. To manage this problem, high-dose loop diuretics are often required. As kidney disease advances, the response to diuretics becomes less predictable due to reduced renal blood flow, tubular dysfunction, and transporter competition. Higher doses may be necessary to achieve adequate drug concentrations at the site of action and overcome diuretic resistance. This case highlights an important principle of chronic kidney disease management. Treatment extends beyond preserving kidney function. Clinicians must also address anemia, mineral and bone disorders, and fluid overload. By targeting these complications early, it is possible to improve symptoms, reduce morbidity, and enhance overall patient outcomes in advanced chronic kidney disease. As we conclude, it is important to clearly distinguish between acute kidney injury, or AKI, and chronic kidney disease, or CKD. Although both conditions affect kidney function, they differ significantly in their onset, progression, clinical implications, and pharmacological management. The first major difference is the speed at which they develop. Acute kidney injury occurs suddenly, often within hours or days. A patient may experience a rapid decline in kidney function following severe dehydration, sepsis, major surgery, exposure to nephrotoxic drugs, or urinary tract obstruction. The change is abrupt and often clinically obvious. Chronic kidney disease, on the other hand, develops gradually over months or years. Kidney damage accumulates slowly, and many patients remain asymptomatic during the early stages. Because of this silent progression, chronic kidney disease is often discovered during routine laboratory testing rather than through dramatic clinical symptoms. Another key difference involves reversibility. Acute kidney injury is frequently reversible if the underlying cause is identified and treated promptly. Restoring blood flow, correcting dehydration, treating infection, or removing nephrotoxic agents can allow kidney function to recover partially or even completely. Chronic kidney disease is fundamentally different. Once significant nephron loss and scarring have occurred, the damage is generally irreversible. Treatment focuses on slowing disease progression, preventing complications, and preserving remaining kidney function rather than restoring lost nephrons. The diagnostic criteria also differ. Acute kidney injury is diagnosed by evidence of a rapid deterioration in kidney function. Clinicians look for an acute rise in serum creatinine, a decline in urine output, or both. These changes reflect a sudden reduction in the kidney's ability to filter blood and maintain homeostasis. Chronic kidney disease requires evidence of persistent kidney damage or reduced kidney function for more than 3 months. This may include a glomerular filtration rate below 60 milliliters per minute per 1.73 meters squared, persistent albuminuria, structural abnormalities on imaging, or other markers of chronic kidney injury. From a pharmacological perspective, both conditions share one critical principle. The kidneys play a central role in drug elimination. Many medications and their metabolites depend on renal excretion for safe removal from the body. When kidney function declines, drug clearance decreases. Medications can accumulate, active metabolites may build up, and the risk of toxicity rises substantially. This is why patients with AKI or chronic kidney disease often require dosage adjustments, therapeutic drug monitoring, and careful assessment of medication safety. One of the most important tools in clinical pharmacology is the estimation of kidney function through creatinine clearance, or CRCL, and related measures such as eGFR. Regular monitoring allows clinicians to adjust drug doses appropriately and avoid preventable adverse drug reactions. The key message is simple. Acute kidney injury develops suddenly and is often reversible, whereas chronic kidney disease develops gradually and is usually progressive and irreversible. Despite these differences, both conditions profoundly affect pharmacotherapy. Because the kidneys are major determinants of drug elimination, continuous assessment of renal function is essential to optimize treatment, maintain efficacy, and prevent potentially life-threatening toxicity. Let's test our understanding with 3 high-yield clinical questions that reinforce some of the most important concepts in acute kidney injury. Question 1 asks which drug class can precipitate prerenal acute kidney injury by inhibiting protective afferent arterial vasodilation. The options are angiotensin-converting enzyme inhibitors, nonsteroidal anti-inflammatory drugs, and diuretics. The correct answer is nonsteroidal anti-inflammatory drugs. To understand why, remember that the kidneys rely on adequate blood flow to maintain filtration. When renal perfusion falls, the body produces prostaglandins that dilate the afferent arteriole, helping preserve blood flow into the glomerulus. Non-steroidal anti-inflammatory drugs block prostaglandin synthesis. Without these protective prostaglandins, the afferent arteriole constricts, renal blood flow decreases, and glomerular filtration rate can fall. This makes non-steroidal anti-inflammatory drugs a well-known cause of prerenal acute kidney injury, especially in elderly patients, dehydrated individuals, and those with pre-existing kidney disease. Question 2 involves a patient with sepsis who develops acute kidney injury. Urinalysis reveals a fractional excretion of sodium, or fractional excretion of sodium, below 1% and the presence of hyaline casts. The options are nephrotoxic acute tubular necrosis, prerenal acute kidney injury, and acute interstitial nephritis. The correct answer is prerenal acute kidney injury. A fractional excretion of sodium below 1% suggests that the kidneys are actively conserving sodium. This is a classic physiological response to reduced renal perfusion. Hyaline casts are also commonly seen in prerenal states and are generally considered relatively benign urinary findings. In contrast, acute tubular necrosis typically presents with impaired tubular function, resulting in higher urinary sodium excretion and often muddy brown granular casts. Acute interstitial nephritis usually produces findings such as white blood cells, white cell casts, and sometimes eosinophils in the urine. Therefore, the combination of low fractional excretion of sodium and hyaline casts strongly supports a diagnosis of prerenal acute kidney injury. Question 3 asks which biomarker is considered an early indicator of proximal tubular stress before serum creatinine begins to rise. The options are BUN, neutrophil gelatinous associated lipocalin, and albumin. The correct answer is NGAL, which stands for neutrophil gelatinous associated lipocalin. One limitation of serum creatinine is that it often rises relatively late after kidney injury has already occurred. Researchers have therefore focused on identifying biomarkers that can detect injury earlier. Neutrophil gelatinous associated lipocalin is released rapidly by injured tubular cells and can increase within hours of kidney damage. Because of this early response, it is considered a promising biomarker for detecting acute kidney injury before traditional markers such as serum creatinine become abnormal. BUN is less specific and can be influenced by factors such as hydration status and protein intake. Albumin is primarily a marker of glomerular damage rather than an early indicator of acute tubular stress. The key answers are straightforward. Non-steroidal anti-inflammatory drugs can precipitate prerenal acute kidney injury by blocking protective afferent arterial vasodilation. A fractional excretion of sodium below 1% with hyaline casts points toward prerenal acute kidney injury. Neutrophil gelatinous associated lipocalin is an early biomarker of tubular injury that may become elevated before serum creatinine rises. These concepts are highly relevant in both clinical practice and examinations. Let's finish with two important clinical questions that highlight key concepts in chronic kidney disease and pharmacotherapy. These are exactly the types of principles that help explain why patients with advanced kidney disease require such careful monitoring. Question 4 asks why morphine carries a high risk of respiratory depression in patients with advanced chronic kidney disease. The options are increased volume of distribution, accumulation of morphine 6-glucuronide, or decreased albumin binding. The correct answer is accumulation of morphine 6-glucuronide. Many people assume that the parent drug, morphine, is the main concern. However, the real problem often lies in its active metabolite, morphine 6-glucuronide. Under normal conditions, this metabolite is eliminated by the kidneys. As kidney function declines, the body loses its ability to clear morphine 6-glucuronide efficiently. The metabolite gradually accumulates in the bloodstream and continues to exert potent opioid effects. In fact, morphine 6-glucuronide can be even more pharmacologically active than morphine itself. As levels rise, patients become increasingly sensitive to opioid effects. Excessive drowsiness may develop first. This can progress to profound sedation, reduced respiratory drive, and potentially life-threatening respiratory depression. While changes in volume of distribution and protein binding can occur in kidney disease, they are not the primary reason morphine becomes dangerous in advanced chronic kidney disease. The major issue is the accumulation of this active metabolite due to impaired renal elimination. This is why alternative opioids with fewer active renally cleared metabolites are often preferred in patients with severe kidney dysfunction. Now let's move to question 5. The question asks which electrolyte retention initiates the pathophysiology of chronic kidney disease mineral and bone disorder, commonly known as CKD-MBD. The options are calcium, potassium, and phosphate. The correct answer is phosphate. As glomerular filtration rate declines, the kidneys lose their ability to excrete phosphate effectively. Phosphate begins to accumulate in the bloodstream, leading to hyperphosphatemia. This phosphate retention is the critical initiating event in chronic kidney disease, mineral and bone disorder. Elevated phosphate disrupts the body's mineral balance and contributes to a decline in serum calcium levels. At the same time, failing kidneys cannot efficiently convert inactive vitamin D into calcitriol. The active form of vitamin D, reduced calcitriol, further decreases calcium absorption from the gastrointestinal tract. The combination of high phosphate and low calcium stimulates the parathyroid glands to release large amounts of parathyroid hormone, or PTH. This process is called secondary hyperparathyroidism. Over time, persistently elevated parathyroid hormone causes increased bone resorption, weakening the skeleton and contributing to renal osteodystrophy. Excess calcium and phosphate may also deposit in blood vessels, leading to vascular calcification and increased cardiovascular risk. The key answers are simple. Morphine is dangerous in advanced chronic kidney disease because morphine 6-glucuronide accumulates and causes profound respiratory depression. Chronic kidney disease, mineral and bone disorder begins with phosphate retention, which triggers a cascade of hormonal changes affecting both bone health and cardiovascular function. These are essential concepts for safe patient care and successful examination performance. Thank you for your attention during this clinical pharmacology tutorial. The material covered today synthesizes guidelines from KDIGO regarding the staging and management of both acute and chronic kidney injury, alongside established principles of renal physiology and pharmacokinetic adjustments. Recognizing the interconnectedness of renal function and drug metabolism is the cornerstone of safe, effective prescribing. This concludes our presentation.